Neurologist is very important in this case. We have come across cases of many patients just having serial extractions. This is what we usually see in adults. So we should think about trigeminal neuralgia. That's what I want to point. Thank you.
My question is, as you know, trigeminal neuralgia is going to be managed first as medication, then it's going to be managed later on with surgical management. But when we see for clear-cut demarcation for surgical indication, trigeminal neuralgia will go to with exacerbation, then it goes with remission. So, which is cannot be managed with carbamazepine. So, when we start the surgical indication for trigeminal neuralgia, and the other management is going to be plan is 100% alcohol injection on the distribution of trigeminal neural nerve. So, can we apply 100% alcohol injection? Is it effective? Thank you.
Nerve at the entry point where it enters to the pons. So this is not the only finding we may find. Sometimes we may find meningioma or cerebropontine angle tumors or trigeminal schwannoma could also be some of the causes for trigeminal neuralgia. And it's likely that we may find some structural causes for trigeminal neuralgia in patients with symptomatic, especially having neurologic finding. It may be sensory deficit or motor deficit. So these are some of the findings we may expect after imaging the individuals. The age cutoff point less than 40 is that, as I've tried to explain earlier, the incidence of trigeminal neuralgia is quite high after the age of 50 years old in the elderly for this matter. So in age ranges less than 40 or younger individuals, it's highly likely that we may find some structural finding which is the offending cause for the trigeminal neuralgia. So for this reason, we need to have a low threshold to image individuals with younger age of onset. And I can take it as a comment, the last questions. It is true that sometimes we may not come up with any obvious cause for facial pain, including individuals with dental caries or so. So rather than going for dental extraction or any invasive procedures, we still need to look for other neurologic causes or for that matter, like glossopharyngeal neuralgia. Still, some individuals may not respond to medical management, so we have to keep in mind that carbamazepine is not 100% in relieving individuals from pain. So before we go to dental extraction also, we have to still reconsider our diagnosis once again that it could be due to neuropathic pain. Still, post-herpetic neuralgia could also be one of the causes for the neuropathic pain of facial weight.
Thank you very much for the presenter. And there is one question left, which was raised in relation to neuro decompression and neurocam. I think.
Okay, thank you. I may respond. The other, the less invasive modalities of surgical management of trigeminal neuralgia are basically of destructive kinds of management, like glycerol rhizotomy. It's also called neurolysis. So they are basically of the same category, means they are basically destructive. the decompressive, microvascular decompressive one is, as I've said earlier, is a major surgical management, because, as I've tried to explain here, up to 90% of them are said to be due to presumed vascular compression. So the other minor or less invasive techniques are basically of destructive, like that of neurectomy or so, but they are not frequently recommended as that of microvascular decompressions.
Our conference in giving message to some many cases with multiple extraction with no result. So we have to always put a question mark in our mind whenever you find a patient with repeated dental pain with no relief, because one is extracted and the next time will come as the next one and then the next one. And I have so many patients with such conditions, so I just want to exclamate that if a patient comes with such conditions, let's give attention and not only extraction but think of other causes. Thank you so much.
First of all, before that, your presentation was nice, but my question is, in case of MRI is not available. Most of the trigeminal diagnosis is based on clinical symptoms and signs. Do you think that, depending on the clinical symptoms and signs, having the diagnosis and saying that trigeminal neuralgia is correct or not? Because MRI is not this much available, or other diagnostic is not this much not affordable or available. So what do you think? Thank you.
Let me respond to the first one being alcohol injection. And in our setup, we don't practice any of the surgical treatment modalities for obvious reasons, because we don't have adequate manpower. But in the Western countries, they still practice glycerol injections or infiltration to the trigeminal nerve fiber or root, which is the impending or offending cause for the trigeminal neuralgia. And the effectiveness of these minor surgical procedures as a treatment modalities for trigeminal neuralgia is inferior to that of the open surgical or microvascular decompressive treatment. And the questions or the suggestions with regard to dental extraction in patients coming with dental pain is, as I've tried to explain earlier, for obvious reasons, even distracting or teeth extraction is further creating some more problems without curing what has already been there. So we don't need to extract these teeth for the mere presence of pain. First, we need to optimize the medical management. Again, we need to optimize, because we have to increase the doses of the carbamazepine. We have to add up on some other medical treatments like phenytoin, baclofen, topamate, tricyclic antidepressant, for instance, amitriptyline, we can add up on top of carbamazepine. So we need to be really careful before we extract the teeth for the mere presence of pain. This is what I want to say. So the other one is MRI, as I've tried to explain earlier. We don't need to image every individual coming with trigeminal neuralgia, because sometimes we diagnose individuals on the basis of the therapeutic trial. Rather than costing an individual more than 2,500 Ethiopian birr, we may try on carbamazepine, like in a cost of like less than 50 birr or so. and an individual may try carbamazepine for a couple of weeks or days, and if there is no response, we may try further investigations. But the fact that the pain is not responding to medical management is not an indication for neuroimaging. The indication for neuroimaging are rather these 4 points. So if an individual is not responding to one of those medical management, we have to increase the dose, and it is not really an indication for neuroimaging. And trigger zones are basically those areas exclusively supplied by sensory branches of the trigeminal nerves, and they are said to be more of central structures. I don't know the reason behind why they are really central. Did I address your questions adequately?
Hopefully, yes. Thank you very much. Very encouraging. Hopefully, you'll join us in every of our association meeting. Thank you. He is a neurologic fellowship at Addis Ababa University, Blackline. And thank you very much. Anything to add, Dr. Mespen? Okay.
ወደፊት የኢትዮጵያ የጥርስ ሕክምና አጀማመርና እስካሁን ድረስ የደረሰበት ወይም ታሪኩን እንደዚህ ለመጻፍ አስባለሁ ብሎ ያለ ሰው አለ ከኛው መሀል እና በጣም ጥሩ ሀሳብ ነው። እኔም በልቤ አስቤ ነበረ። ሶርሶቹ አሁን ከእጃችን ሳይጠፉ ታሪኮቹ ወይም ታሪኩን የሚያውቁ ሰዎች ሳይጠፉ ብትቸኩል ጥሩ ነው ብዬ ነው የማስበው። ዶክተር ዮሐንስ ነበረ እና አንዱም አለ እዚህ፣ ከሱ በፊት ያሉ ደግሞ አሉ ሰዎች እና ዶክተር ትእዛዙም አሉ እዚህኛ መካከል። በነገራችን ላይ እንዲሁ ትንሽ ሀሳብ ለመስጠት ያሰብኩት ዶክተር ትእዛዙ እዚህ መሀላችን ካሉት ጋራ የመጀመሪያ 10 ጥርስ ሐኪሞች መካከል ነው የሚመደቡት አይደለ ዶክተር? እና ከዛ በኋላ ደግሞ እነ ዶክተር መኮንን እነ ዶክተር መስፍን እነ ዶክተር መሐመድ ናቸው የመጡት 10 11 12ኛ ሆነው። ከዛ በኋላ እነ ዶክተር ወንዶሰን ዶክተር ታደሰ መላኩ እየተባለ ነው የመጣው እና ዶክተር ገብረአብ እና ምን ለማየት ነው የፈለግኩኝ በዚህችው ሴንቸሪ ውስጥ እንደውም ሃፍ ሴንቸሪ ውስጥ ነው ዴንቲስቶች ኢትዮጵያ ውስጥ ስራ የጀመሩት ወይም ኢትዮጵያ ዴንቲስት ያገኘ ነው within less than 50 years። እና ይህ ምንድን ነው የሚያመላክተው? ይህ ትውልድ እናንተ እኛ going out ነን almost within few years እናንተ the coming in የሆናችሁ ሰዎች ብዙ ስራ አላችሁ ለማለት ያህል ነው። አንደኛ ስለ ጥርስ ሕክምና ስለ አፍ ጤና አጠባበቅም እውቀቱ የሌለው ወይ በቂ ግንዛቤ የሌለው ትውልድ አለ በመካከላችን። በዛው ትውልድ ውስጥ ያለ ነው። እነዛ ደግሞ እውቀቱ ስለሌላቸው በቂ ስለሌላቸው ለልጆቻቸው የሚተዉት ወይም የተውላቸው ብዙ ነገር ያለ አይመስለኝም። ስለዚህ ልጆቹም ወላጆችም አያቶችም በዚህ ክሪቲካል ፖይንት ውስጥ ነው ያሉት ማለት ያው አንድ ካቴጎሪ ውስጥ ነው ያሉት ማለት ነው። ስለዚህ ስራው ሰፊ ነው ለማለት ያህል ነው እና ኮኦፐሬት እየተደራረገን ያለፉትንም ሰዎች እንዲሁ ኮንሰልትም እያደረግን ሰፋ ያለ ደግሞ ኮንቲኒንግ ሜዲካል ኤጁኬሽን ሊኖር የሚችልበት ሁኔታ ይከፈታል ብለን እናስባለን እናምናለን። እና ይህንን ነገር እድሉን እየተጠቀምን ኮምፐተንት የሆነ ጥሩ ዴንቲስቶች እንዲወጣን መትጋት ያስፈልገናል። የሚገርማችሁ እኛ ስራ ስንጀምር መጀመሪያ የተማርንባቸው የተለያዩ ቋንቋዎች ናቸው። እኔ በሃንጋሪኛ ከዛ በጀርመንኛ ነው። እነ ዶክተር ወንዶሰን በቼኮስሎቫኪያን ላንጉዌጅ ነው የተማሩት፣ ሌሎቹ ራሽያን እና ብዙ ሬፈረንስ መጽሐፍ አልነበረንም። አሁን ግን ቡክወርልድ ብትሄዱ ኢንክሬዲብል ምንድነው ሪላያብል ቡክ ስቶር ብትሄዱ ብዙ ዴንታል መጽሐፍት አሉ። ጥቁር አንበሳ ውስጥ ዴንታል መጽሐፍት ብዙ የሉም፣ ቢኖሩም በጣም ጊዜ ያለፈባቸው ናቸው። የምንፈልጋቸው ፊልዶች ሁሉ ከቨር የሚያደርጉ አይደሉም። እና አሁን ጥሩ ቻንስ ነው ያላችሁ ለማንበብም ለመማርም ለመማማርም። እኔ ልንገራችሁ ኢንተርንሺፕ እንኳን ባልነበረ ጊዜ ነው የመጣሁት። ያን ጊዜ ማንም ኦሪየንት የሚያደርገኝ አልነበረም። አንድ ብቻ ሃንጋሪያዊ ዴንቲስት ባልና ሚስት ነበሩ። አንድ ኦራል ሰርጀን፣ አንደኛ ደግሞ ዴንቲስት ነበረች የካቲት ሆስፒታል። እሷ ጋር ደሴ ተመድቤ እየመጣሁ ከእነሱ ነበር መማር የነበረ ማለት መማር ሲባል ሃንጋሪ ነው የተማርኩት እዛው። ግን እነሱ አንደኛ ሃንጋሪኛ ይችላሉ፣ ሁለተኛ ደግሞ እዛ የነበረውን መድኃኒት ስሙን ወደዚህ ሲቀየር ምን እንደሚመስል እኔ ባክቴሪየም እዚህ ነው የሰማሁት። በፊት ሶሜትሮዲን በሚል ስም ነው የማውቀው የነበረ እና ትራንስሌት እንኳን የሚያደርግልን ማለት እዚህ አቬለብል የሆነ ብራንድና ያኛውን የሚያገናኝ ሰው ድልድይ አልነበረም። አሁን ግን እዚህ ትማራላችሁ። አብዛኛው በእንግሊዝኛ ቋንቋ ትማር፣ መጽሐፍቱን ሞልተውላችኋል እና ማንበብ ከኛም ከእናንተ የሚጠበቀኛ በድሮ ስለተማርን እዛ ራሳችንን ሪፍሬሽ ማድረግ ስላለን እናንተ ደግሞ እድሉ ስላላችሁ እናንብብ፣ እንማማር ለማለት ያህል ነው። እግዚአብሔር ይስጥልኝ።
እሺ፣ እግዚአብሔር ይስጥልን። የምሳ ሰዓት ነው። መልካም ምሳ ይሁንላችሁ።
Just now we are going to have two presentations. The first presentation will be by Dr. Mokonin Nwai. The topic was caries as dental infection. As we know that dental caries is the common cause of orofacial and odontogenic infection. So Dr. Mokonin will present us about this topic briefly. Thank you.
Why I said caries as dental infection, or is caries at all infectious disease? This is really a question, but to start with, we have to know what is caries. Caries is a pathologic cavity of the hard surface of the tooth, which is manifested by demineralization of the hard substances. So this process, as you know, there is bacteria, there is food stuff, there is time, and there is bacterial product as well, and this combination causes caries. But when you see caries is not an infectious disease, but at the end of the whole process, caries causes infection. When we deal with what we call pulpitis and so on, we can see that caries is an infectious disease of the tooth. So after saying that, I will just go to the main point, how this caries lesion causes infection. That means the caries at that process, it causes the pulp chamber. You call it edema, or you call it pain, something else. Then at the end of that, it comes to infection, peritonitis, abscess, and so on and so forth. All the worst thing follows after the caries cavity. So now I go how to protect this one. I will not discuss infection, but how we protect the infection. To protect the infection, we have dental material when you have a cavity. Then we have bases, we have liners, and we have sealers. You have seen the cavity. So how we go on? considerations for pulpal health in the placement of restorative materials. First of all, we have to consider compromises to pulpal health, pulpal irritation. We have to protect pulpal irritation, carious bacterial infection causing pulpal infection, rotary preparation, heat, and trauma to odontoblastic process. This process I will not touch because this is more molecular odontoblastic process. But when you prepare a tooth, if you don't have cooling, you will cause infection. Why? You will kill the pulp. The killed pulp, the dead pulp, will cause infection. So, our goal is, on the whole treatment, to protect the pulpal health, because the pulp is the most important part of the tooth. Without pulp, there is no tooth. Now I will not raise the root canal treatment and so on, but this is the most important. We have to create a barrier to stop the infection. And we seal any marginal places, because how caries goes to damage the pulp? From two places. One directly from the cavity to the pulp. The other one is it goes to the pocket. The infection goes inside to the root apex and kills the nerve and comes up as infection. There is another way of infecting the pulp. It's not only by caries. So why we raise here sealing? If all our fillings are hanging, our bridges are hanging, our crowns are hanging, without opening the pulp, will kill the pulp chamber from downwards. So there is decision making in using of these sealers. You can see this, maybe it's not visible for you very much, the caries cavity over here, and that caries cavity is, when it is very deep over there, so we have to think about the pulp, what to do. There are so many things to cause death of the pulp, the termites, sweat, and so on and so on. But how we diagnose if the pulp is already unhealthy? The only simple test is the cold application test. If the pain is longer, then the pulp is not healthy. So we cannot feel it. We have to think of root canal treatment. So, also we have to think about the dentin thickness. Each tooth has got its own dentin thickness, but also after the cavity formation, the dentin thickness changes. Why it changes? Because the dentin always, if the process is slow, the caries process, the dentin produces secondary dentin. If you have seen some people, they have dark cavity. That's the secondary dentin. Most of the time, the process will not so far. So you can see the depths over here, and you can see also here how the deep fissures can cause cavity formation, and how you can diagnose radiologically, because using the bite wing X-ray. What are the causes of pulp inflammation? That is bacterial toxins penetrating the dental tubules, so directly to the nerve. But there are reasons of the enamel is damaged. There are dental tubules through that the bacteria penetrates. Bacterial can cause pulpal irritation, pulpal necrosis, recurrent caries, and so on and so forth. And you can see this caries, for example. That's what I call the secondary dentin. It's a very great barrier. It will stop, the tooth from being infected, the pulp from being infected. So bacterial invasion at gap between restorative tooth interface, restorative material, bacteria penetrating gap, invading dental tubules, inflammation. After this process, the pulp starts to be inflamed. So this will be seen by pain. What type of pain? Up and down coming pain, but sometimes elongated pain. And pulpal pain, as I said before, because of stimuli. You call it cold or hot. When it is hot, it's really there is a process changing into infection. How we use sealants after we prepare the cavity, and we are sure that the cavity is no more damaging the pulp is really healthy. So how we go on? So we have to see the marginal gaps, this gap. That's the most important place to the health of the retrograde pulp infection. So the pulp is the tooth happy substance is okay. We are putting the filling, but we have to seal around that any infection will not penetrate into the pulp through the gingival margin, through the pocket. This all goes, we have to think also about cleaning and so on and so on and so forth. Why are these sensitive to the thermal shock? Usually, cold stimulus response postulated that direct thermal shock transfer to pulp through thin dentin. Metallic restorations more thermoconductive. That's why if we feel amalgam, we have to put a sealer under the amalgam, which protects the thermal condition, because amalgam is heat producing, because easily it can be heated and the pulp can be damaged. And we have to think about how to put the base. In this context, we have to think what we do. For example, there is direct pulp capping and indirect pulp capping. Direct pulp capping is when the pulp is damaged dramatically, not which cases. Indirect is when pulp is okay, no damage to the pulp, but the cavity is very deep. There is a thin layer of dentin. So we will put indirect pulp capping, then we put sealants or under base fillings before we put any amalgam or other available filling materials. There are so many materials we use for protection of the pulp. Most of them are the varnish or calcium hydroxide dical and glass ionomer bitter bond. These are one of the most common instruments, and it looks like this when we see them in group. When we fill, of course, there are cavity sealers. As I say, there are two forms of cavity fillers: varnish, natural gum or resin dissolved in organic solvent. Brand name barrier. This is just for advertisement, I think. Adhesive sealers, bonding agent. So the bonding agents, there are different bonding agents. There are bonding agents which have got different layers. There are bonding agents which are one, and there are other bonds bonding and etching together. They call them I-bond. There is I-bond material. It etches the enamel and the dentin, and it bonds the filling. So according to their use, they are expensive regarding their use. I-bond is very expensive one. This is the dical which is common, and this is glass ionomer cement. As you know, glass ionomer cement, after you mix, if you are hurry, you just press it and clean surrounding, it will dry, it sticks very nicely. So it is very advisable to use that one. There are guidelines for basing, lining and sealing. It says, do not remove healthy, sound tooth structure to provide space for base. This is for most of the young doctors, this is the problem. When you prepare the tooth, you will get deep. Why? Because your hand, the handpiece and the brain, they are not coordinating so easily. It needs practice. So at that time, I have seen they penetrate most of the time. So our hand, our brain, our thinking, and the handpiece and the rotation, they must coordinate. It will come due time, but when we are serious, when we do it properly every time, with mistake but properly, then we will override the mistakes and we'll start doing the right treatment. What are the recommendations for composite no, sorry, I'm sorry here. Recommendations for amalgam. There are two fillings, strong fillings, composite and amalgam. Shallow cavity depths. Sealer, we put sealer first if it is okay with the thickness of the dentin. We put sealer and then amalgam. If it is moderate, we put glass liner, then filler, then amalgam. Deep cavity, very deep one, we put calcium hydroxide because just were indirectly pulp capping to protect the pulp. Then glass cement, then sealer, then amalgam. So this is a very important step. If it is composite, we put sealer, then comes composite resin. If it is moderate, we put glass liner, sealer, and composite. Deep cavity, we put calcium hydroxide, glass ionomer, sealer, composite resin. So in this etap, we will do our restoration successfully. What are materials used with amalgam? There is varnish, there is resin adhesive. If it is with cavity liner, there is calcium hydroxide dical, resin modified glass ionomer, white bond. Cavity base, resin moderate glass ionomer, white bond, Fuji. There are so many materials at this time. So the choices depend upon our country's import activity. The dentistry actually, the quality of dental treatment depends to the quality of the materials which are available in the country. And the same quality of work, the quality of the doctor comes after this one. If there is no material available, we cannot create quality doctors. If there is no material available, we cannot create scientist doctors. They cannot read and become scientists. They have to work, they have to make mistakes, they have to write the mistake, they have to solve a problem, they become quality doctors and scientists, and the country will have a good dental service as well as dental training. The materials used with composite is the same. There is no much change. Dispensing and mixing materials. Well, calcium hydroxide or dical, we dispense in length. There are two of them, the activator and the base. Just you have the same amount and mix them fast. Then you can do your fillings and your filling will be a successful one. the same thing goes with this one, but it's a powder. Dispense on drop liquid, and then you put this, and I will not go to these details. But now, look the clinical application of deep cavity preparation. Look, they have prepared this cavity and they made it very nicely. And you see, it's very deep, but still the pulp is okay. I think because you have just tested it with cold application. Cold is painful at that time, but when you remove, it must stop. You ask the patient, are you still in pain? He says no. When you put it, I have pain, so the pulp is okay. So we have to use also, if we have rubber dam, we can use rubber dam. Some of us, it is also difficult to put rubber dam, but we can learn that. But it's expensive to use rubber dam for some patients. This is how we put butter bond as linear. The whole thing, what I want to show you is how to prepare the cavities. Look, the cavities, they have got a shape. It's not as we put our handpiece and do clean and feel, and the patient will come after 2 weeks. He says, my feeling has gone, or that was broken. So this is important, the cavity preparation. Because the materials, I'm not worried because you can read it. There is a paper in it. So clinical application vitamin is all the same. Look now, how to you use a wedge. Just to the stick, take to the stick, make it sharper, and start using wedges when you are doing fillings. If you don't push the gum, you will feel everything into the gum. I've seen most of the fillings after I take the X-ray as hanging things. That's the most notorious filling, and that causes the pulpitis without touching the pulp. It goes from the pocket. Clinical application with Dical and Vitawork, the same process. But still I want to show you is how they prepare the cavity and how the amalgam filling looks like real. So our instrument makes it. Even without many instruments, you can use a probe and make this shape. Just you have to be a little artist. Not theater artist, but painter. So that's very important. So dispensing and application of cavity varnish barrier and so on, I will not go through this one because the time is limited. There are kits for filling materials. This is one brand and there are so many other brands. So dispensing and application. And there are light cure materials different with different applicators. But the most important is, could we use these brushes to apply the varnish, to apply the etching, the material and so on? Oh, we are poor, we cannot. But just make a small cut and roll and apply that one, no problem, with a pencil. This is very important because we have to know what materials we are using. What is the indication? What is the nature of the filling material? We have to read twice the leaflet, then make a note, and tell our assistants also these characteristics of the materials. If we just follow these methods and ways and sequences, our fillings will stay, the patient will be happy, he will be economized, and he will love us.